Hi, everyone. I'm Susan Thornton, the CEO of the Cutaneous Lymphoma Foundation, and I'd like to welcome you today to one of our educational programs as part of our efforts to keep everyone informed about medications and therapeutics so that you can have an educated and meaningful conversation with your physician. And we've created this series of industry spotlights to really allow you to get to know the individual medications that are most commonly used in treating cutaneous lymphomas, which of course includes mycosis fungoides, Sézary syndrome, and all the various subtypes. Today, we're going to talk a bit about two particular drugs and the company that makes them. And of course, this information does not take the place of speaking with your doctor about your therapies and your therapeutics. But today we're going to talk about one of the first treatments approved for treating cutaneous lymphomas, TARGRETIN gel and TARGRETIN capsule, also known as bexarotene. So you may have heard both terms. And they are both made by a company, Ortho Dermatologics, which is a division of Bausch Health based in New Jersey. So TARGRETIN gel and TARGRETIN capsules are obviously prescription medications that are used to treat cutaneous T-cell lymphoma, or CTCL as we all know it. And after treatment with at least one other type of medication that did not work or has stopped working. And TARGRETIN gel can be used for topical treatment of CTCL or mycosis fungoides, and for lesions often referred to as patches or plaques on your skin. It's not known if TARGRETIN is safe and effective in children at this point in time. And TARGRETIN can cause some serious side effects, including major birth defects to an unborn baby, so if it's taken during pregnancy. So we'll be covering some of those things in more details, but it's important to note that information and to speak with your physician about that and where you are before taking any medications, to look at the side effects and understand the safety profiles of everything. So with that, we have a wonderful team of experts and a panel joining us today, and each have had integral roles in different ways in the development and clinical use of TARGRETIN and bexarotene. So I'd like to introduce everybody. Dr. Erin Boh is a physician, PhD, and a fellow of the American Academy of Dermatology. She is the Joseph Chaston Endowed Chair of Clinical Dermatology and professor and chairman. Dr. Boh trained at Tulane University School of Medicine in Louisiana and completed her residency at the University of Texas Southwestern Medical Center Parkland Hospital in Texas. And she joined the faculty at Tulane University School of Medicine in 1990, is currently professor of dermatology. Dr. Boh has a deep clinical research experience in cancers such as cutaneous lymphoma, as well as photobiology, chronic skin diseases like psoriasis, and Dr. Boh is certified by the American Board of Dermatology. And I'll also mention Dr. Boh has joined us many times for our patient programs when we've hosted them down in her neck of the woods near New Orleans. So thank you, Dr. Boh, for joining us today. It's really a delight to have you. Secondly, I'm pleased to introduce Michael Young, who is a former member of our board of directors, recently just rolled off our board actually after 25 years. He's been definitely engaged with the foundation for a long time and has now joined our foundation board of advisors. But Michael has been was a member of the original pharmaceutical team that developed TARGRETIN bexarotene and actually brought the drug to market. And so he's been engaged in the cutaneous lymphoma space for a very long time and has been volunteering with us at the foundation, as I said, for pretty much our whole history with 25 years, and still is a big supporter of the mission and patients. So it's really exciting, and I'm thrilled to have Michael here, and it's great to have you. And I think this will be really fun and interesting because most patients don't really understand or know how a therapeutic has gotten here, especially one that we've been using for a long time. So it'll be fun to go over the history. So thank you, Michael, for joining us. And lastly, we have Don Pearl. And Don is the Senior Vice President for Ortho Dermatologics, and the company that produces and manufactures and makes available TARGRETIN gel and TARGRETIN capsules. And Don, it's really great to have you with us as well to kind of round out our panel. We'll talk a little bit about everything today. So thank you, everyone, for joining us. And now I'm going to kick it over to Michael Young, who is going to take us through some of the history and a little history of cutaneous lymphoma, and a history of how we got to where we are today with TARGRETIN. So Michael, over to you.
Thank you, Susan. I'm pleased to join today's expert panel, and I hope all of you that are watching this will gain some important insights. Cutaneous lymphoma, the disease that we've been discussing, is diagnosed in roughly 2,000 to 3,000 new patients each year. Most newly diagnosed patients can expect their disease to ebb and flow over many years, and as a result, there are about 30 to 40,000 patients who are actually living with cutaneous lymphoma in North America. It's considered an orphan disease because of its uncommon diagnosis, and the US Food and Drug Administration, or better known as the FDA, shows that it has an overall prevalence of fewer than 200,000 people. Mycosis fungoides, or MF, is the most common form of cutaneous T-cell lymphoma, CTCL as we call it abbreviated. And although the terms MF and CTCL are often used interchangeably, this can be a source of confusion. All cases of MF are CTCL, but not all CTCL cases are mycosis fungoides. You can take a look at the little diagram that's being shown to help you. Mycosis fungoides generally follows a very slow, chronic, or what's called an indolent course, and very often does not spread beyond the skin. In about 10 to 15% of the cases, MF can progress in the skin, and beyond the skin symptoms of mycosis fungoides can include flat, red, scaly patches, thicker raised lesions called plaques, and sometimes large nodules called tumors. Mycosis fungoides can look like other common skin conditions in the early stages, such as eczema or psoriasis, as you can see in this slide. It might be present for years or even decades before it's diagnosed accurately as CTCL, and this disease can progress over many years, often decades. And that's one of the reasons why it's considered an indolent form of non-Hodgkin's lymphoma. Patients early in the disease process are often prescribed topical treatments for skin-directed use in the form of creams or ointments that are applied directly to the lesions. For those with progressive disease covering more than 10% of their body surface area, clinicians often prescribe systemic medication that is taken orally or injected through a needle. CTCL was first described in the early 1800s by the French dermatologist Baron Alibert, over a century before there were any clinically effective treatments. The drug, TARGRETIN, was studied in a series of steps or phases to learn about its risk and effectiveness. Based on all the data collected, the FDA approved it for use in 1999. Treatments vary from patient to patient depending on symptoms, stage of disease, and your personal health profile. Treatments are either directed at the skin, called skin-directed therapies, or the entire body, known as systemic therapies. It's important that patients discuss fully with their physicians all the treatment options before deciding on a course of treatment. Skin-directed therapies include ultraviolet light, also called PUVA or narrowband UVB. There are topical steroids, topical chemotherapy agents such as nitrogen mustard and carmustine. There are topical retinoids, local radiation to single lesions, or total skin electron beam radiation, TSEB. As most patients with CTCL have skin disease, in addition to topically applied TARGRETIN gel, there is a lot of ongoing active research into new topical therapies. Full body or systemic therapies include oral retinoids, like TARGRETIN capsules, which are taken by mouth, photopheresis, interferon, targeted agents, antibody therapies, immunotherapies, and systemic therapy, chemotherapy. These treatments are all different, and we'll be talking more about these in future focuses. As noted earlier, skin-directed therapy, including TARGRETIN gel, is typically used in early stage, what we call stage 1A and 1B. These systemic therapies are often necessary if their disease progresses or if patients are not responding to skin-directed therapies. TARGRETIN capsules are a systemic therapy that can be used in patients whose prior systemic therapy didn't work or stopped working. Your doctor may also choose to prescribe TARGRETIN capsules if you did not tolerate the first systemic approach. So now we'd like to turn our attention to some of the clinical perspectives of treating cutaneous T-cell lymphoma. And so in terms of an introduction to various therapy options, I can't think of anybody better than Dr. Erin Boh. So how do you see physicians, Dr. Boh, in general, diagnosing CTCL?
Thanks, Michael, for that intro. And I have to say, CTCL is not an easy diagnosis to make. And yet I like to say it is easy to make, but you have to understand the disease process. And so I think you covered that quite nicely. Because it's so indolent, the early stages of MF or even cutaneous T-cell lymphoma can actually mimic other disease states that are benign. And we see this every day in clinic practice. We see patients who have eczematous eruptions, psoriasis-like eruptions. So initially, because of its indolent nature, the diagnosis may go miss. So the best way to diagnose it is to think about your clinical presentation. Think about when things aren't responding as they should to those commonly used therapies for common diseases. How do we do this? We do a biopsy. And I tell people all the time, residents, other doctors, it's absolutely the best thing to do multiple biopsies if you need to, especially in the early disease process, because you will get better yields on your information if you do that. And so consider biopsying different locations. If patients have a clinical presentation, which may be eczematous in one spot, more psoriasiform or lichenoid in another, you do multiple biopsies on the different patterns of disease. And that helps to increase the yield on our diagnosis when we get our biopsies. And again, that's something to think about, and we'll talk later about the clinical presentation. The key is looking at the patient and seeing do they fit a particular pattern. Different morphologies, then we would want to do different biopsies so that we could get the diagnosis. In general, I like to tell the patients as well that this may be a process to get to the diagnosis. So when I see a patient in consultation, I say we may need to biopsy again or at different times when the disease changes. And so that helps us in seeing the disease from a different perspective than a common dermatosis.
That's very helpful, Dr. Boh, and it's really descriptive around what it is that we're dealing with, especially with early stage patients who don't really know what extent or what stage they might actually be. When it comes to the types of therapy that you might select, what's typically in this stage or this early part of things here that you might consider, including TARGRETIN? Will most patients be offered in their treatment journey a specific set of treatments?
So again, it comes back to the patient. We look at what the disease state is in that patient. So if they have an early patch plaque stage, which is usually, stage 1, and we heard from the patient that they have had this rash for 5-7 years, we know that that's going to be an indolent form, i.e. maybe mycosis fungoides. So what I like to do is after I've gotten my diagnosis, whether it's with 1 or 5 biopsies, and that actually turns out to be the case very commonly that we do multiple biopsies to get the diagnosis. If it's an early patch plaque stage, rather indolent, we look at the body surface area. If we see that the patient has 2%, 5%, maybe even all the way up to 1B stage, which is 10%, If that patient fits the model, then we could use topical, and we should use topical or skin-directed therapy. Early disease, 2-3%, it's very amenable to topical steroids, right? So that's a nice one to use, but other topicals come into play as well. When we look at the staging, we see early patch plaque is stage 1, A is less than 10%, stage 1B is greater than 10%. But they can still both have scaling, eczematous, and itchy rashes, right? And so then we have to go and do a little bit further investigation. Do they have palpable lymph nodes? And that might put us then into stage 2A. But again, it's also with the amount of body surface area affected. So we can base our early diagnosis and staging on the extent of the skin involvement. So in this case, the tumor burden is very important for us to assess so that we can get to the right stage. And if we get to the correctly stage that patient, we can have a better handle on giving them a prognosis. So with early patch plaque disease, we know the prognosis is excellent, and you should use skin-directed therapy. And that skin-directed therapy should fit the patient's lifestyle. I tell people all the time, I don't shoot to cure this very often. I shoot to control it and make the disease be part of your life and not your whole life, so you can just manage it quite well. So when we have topicals, we have a number of different topical therapies that we can use. I mentioned topical steroids, corticosteroids. We have newer topical retinoids such as bexarotene or TARGRETIN gel. We even have anti-cancer metabolite drugs like carmucin and nitrogen mustard, which we can use very, very safely and comfortably when you have a limited patch plaque disease. Now, it comes down to a little bit different, and we have to start thinking a little bit differently when we start getting thicker plaques or maybe bordering on tumor. Why? Because one, that puts us to a different stage, but two, it also importantly, when we get to a different stage of disease, the prognosis can change. And we need to then rethink how we're going to approach a patient who may not have such quite indolent disease. And then we have to start thinking systemic therapies, but still can be directed to the skin in that regard. So it doesn't mean you have to go to conventional chemotherapy once you start getting greater than 10% body surface area or thick lichenoid plaques or even early tumors. We can use skin-directed therapy such as phototherapy, which was mentioned earlier. PUVA is a great therapy to use. So is narrowband UVB for patients who can't do topicals or frustrated with it, or topicals are not where you're supposed to be at this point. Thick lesions don't respond as well to monotherapy with topicals. We can use these topicals as adjunctive therapy all throughout the disease course and clinical course of the disease. So we have other things that we can do besides just topical. And we can do combination of phototherapy with topicals. We can do oral agents, or we can kind of combine things that work for the patient and for their disease state. And what do I mean by that? Well, phototherapy, I said, is an excellent modality to use, and we can get quite effective remissions with that, but that's time consuming. People may work at a job where they can't get off of work to go to the phototherapy unit, which you need to go to 2-3 times a week. If you're taking PUVA, you have to take pills with it. So it can be difficult for people who are busy with their work or they travel for work to get that as an option. Now, fortunately, we can get sometimes home units, but that doesn't work for everybody. So then we have to think, well, are there skin-directed therapies for the patients who are past patch plaque stage? So your 2As and even your 2Bs. And that's where I start thinking about systemic therapies. But again, systemic therapies such as the oral retinoids, like bexarotene, like TARGRETIN, like even chemo agents like methotrexate are all useful, and they still don't get us into that very scary chemotherapy mode that most patients relate to when they think about having a lymphoma. So we have these new targeted therapies, and I mentioned one just a minute ago, bexarotene or TARGRETIN, that homes in on the malignant T cell and some of the receptors that they express on their cell surface, and it helps to modulate and actually kill or be tumoricidal to those cells. So we want to think of targeted therapies for this disease. Targeted agents become very safe when monitored correctly, and they are very useful because they tend to have less spillage into the good T cells that we have left. But not everybody can take bexarotene or targretin. So we know that there are other systemic agents, such as oral methotrexate, which has been around for a good 50 years. And we've used it in treating mycosis fungoides and other forms of CTCL quite effectively. And so there are still other agents that we can use, such as methotrexate, that will help the patient before really going into really the systemic chemotherapy arena. And so that is something that we want to keep in mind. Another skin-directed therapy, which is good for isolated tumors. So say you have a patient who's got pretty reasonable disease, 2A or maybe 1B, and they have 15, 20% involvement, but they pop up with 1 or 2 little isolated tumors, which can happen very commonly. So we can still do therapy such as radiation, and we can do spot radiation. If the patient has a much larger tumor burden or more tumors, we can even use total body electron beam therapy, which is quite effective and still skin directed. And so I think that's something to keep in mind, that as we diagnose and begin treating MF patients in your derm clinic, you should feel comfortable that you have a lot of skin directed therapies. Now, I do think it's important early on for people to get plugged into an oncologist, if just to kind of be introduced. And that's what I like to tell my patients. If they're bordering on 10%, they may be in that group that's going to progress. So I say, let's go see the oncologist just to get introduced, so that if or when your disease progresses, you've already established a pipeline. And so it's working with those oncologists. And I recommend strongly, when you send them to the oncologist, make sure that oncologist is familiar with CTCL and with MF in particular, because many oncologists have never seen an MF patient. And so you don't want to put their lives into a person's hands who hasn't seen it and not familiar with it. So learn your oncologist before sending a patient to the oncologist. And now the oncologists working with us, have a number of systemic chemo agents, which are also targeted, so less toxic side effects, that are specific for cutaneous T-cell lymphoma, and they are quite effective.
So Dr. Boh, thank you very much for those insights. It is very apparent that your experience is invaluable in understanding, how to look at each individual patient. I want to take you back a little bit more to the early stages of the disease and looking at the overall spectrum and the way patients might progress through the disease. Many of these patients, as we noted earlier, don't actually progress very quickly at all, or if at all. And as you remarked, this is really an indolent disease. I'm kind of curious here, at what point does it actually make sense to move, let's say, from a topical treatment like a targretin gel to a more systemic approach like an oral targretin? I mean, what do you look for when you're recommending something like targretin capsules?
So that's a good point. So early in the disease, when it's limited, topicals are absolutely the way to go. And topical steroids have a lot of baggage. So I do like to introduce other topicals into the regimen early on, along with your topical steroids. And I like to use either bexarotene gel, targretin gel, or even the topical nitrogen mustard. So I hold off on systemic therapy when it's limited disease. Okay, so if it's a small BSA, then I think it's reasonable to do that. What I like to do is start patients, if it's amenable, to topical therapy, unless really they can't do that topical therapy. But most people can, and most people do quite well with topical therapy. If it progresses, or they can't do topicals, or there's side effects associated with the topicals, then I think it is sometimes appropriate, especially as the BSA increases, or they start getting palpable nodes but not affected nodes, we may want to add a systemic agent. And I think adding that systemic agent, such as TARGRETIN or bexarotene, that's usually, I think, a reasonable place to start once the BSA starts to increase. If you have a patient who's on topical therapy, it's well controlled, minimum disease, and it does not impact the patient's daily existence, then you stick with topicals. But at some point, patients may get frustrated with topical therapy. They may be having to apply 2 or 3 different topical agents at different times of the day. Now, many of our patients are older, and we didn't discuss that earlier, but older patients are more prone to be the ones who actually get this diagnosis. So maybe it's difficult for them to keep straight that they use this topical in the morning, you use this one before the next one, and it becomes such a regimen that they're consumed by it. Many people have trouble just putting a moisturizer on. So if you're going to ask somebody to put 2 or 3 different topical agents on for little benefit, then it's time to start thinking about moving to a different regimen. Now, we can keep our topical, but we want to add a systemic to that. And I think the thing that I look for the most is increasing in the BSA. So if they're getting more lesions, if they're not responding as readily, or the lesions are thicker, then I'm going to start thinking, oh, maybe we need to do a different skin-directed therapy or systemic therapy. If I'm thinking that they can't do the medicines or it's kind of time-consuming, then maybe phototherapy is a good option. It's another great skin-directed therapy, but maybe they can't get in for phototherapy. They're older, they don't drive, or they're working and they can't get off of work. So we have to think about the patient in this scenario. I don't think that we should say, this is the therapy you need because this is the disease you have. We have the luxury of having multiple approaches to treat this disease today, so we should use them. So my cutoff is, again, if patients aren't real happy or can't manage topical therapy, can't do phototherapy, I start talking about oral agents such as bexarotene or even low-dose methotrexate or something along those lines if we can't do the bexarotene. But again, there's very few patients that falls into a thing where it's absolutely contraindicated. So I think you start having the conversation with patients as you see them back, and they're getting new spots. Yeah, the topicals are working, but they're getting new spots. So they are progressing. So we want to say, oh, maybe it's time to intervene and say, let's reevaluate what we're doing and start thinking about other options. Again, I make the patient be part of this decision-making process, because I don't want to say, you have to do this, because it's easier for me to say that than the patient to do it sometimes. So I want to make sure that the patient is on board. And so a plug here is educating the patient on the disease process makes our job much easier. So if patients know what the disease is like and what to expect, then I can have a better discussion saying, look, you're progressing. It's not bad. It's not the end of the world. Your disease is not uncontrollable. We just moved to the next step. And so that's where we have to have the conversation. So I think getting patients back at a frequent interval to see how they're doing. And I tell this to my residents all the time. Don't wait 6 months to see a patient. If they've got a lymphoma and you're treating with topicals, 6 months is probably okay if you know they're stable, but they've got to know if they start getting more disease, we need to change what we're doing. So I counsel the patients on, if the disease gets more extensive, it starts looking different or acting differently. Now, what do I mean by that? They have little patches of scaly, dry skin, and then they start getting thicker, scaly plaques, or they get in the scalp where they can't get their topicals, or in the genital areas where we have to be a bit more careful when we use our topicals. Then the patients need to be educated, and then they'll make it easier for us. And so some of those are the areas where I say that's time to move to a systemic therapy. I don't know if you understood, but it's more like extensive disease, change in the morphology. What we're offering them as a treatment option doesn't work for their lifestyle. So those are all things we need to consider.
Yeah, that's excellent. I think helping patients understand when it's time to move on to something else is a critical part of helping patients with expectations, and that's really a lot of what you're trying to relate now. So, if you think about that patient who you've now moved to a systemic approach like TARGRETIN capsules, what are the first steps that you want them to understand? How do you set their expectations so that they can get the most out of their TARGRETIN therapy?
That's a good question. And I reiterate to the patient all the time that I am not curing them. So, what I like to tell them also is it's okay if this disease changes a little bit and you start getting a little bit more tumor load. That's the normal progression of this cancer. And so when we see that, that's the time that we start thinking systemic therapy. So if we want to do systemic therapies, we do have to take into consideration more than just, oh, I'm going to give you this pill, right? We need to look at the patient and what their comorbidities are. It's so crucial to understand the comorbidities because you don't want to give them a therapy that's going to make any of those worse. You want to give them a therapy that's going to make them better. And so we have to deal with the comorbidities. And so if we look at, for instance, TARGRETIN or bexarotene as a systemic therapy, if I'm having that conversation with the patients, I want them to know what the potential side effects of that medicine are. So they'll understand why I need to do frequent blood tests on them, right? So they need to understand that. So I think it's important to go over the potential side effects as well as the potential benefits that the patient's going to be seeing from that. So the biggest thing is if you have a younger patient, right? And it's a woman of childbearing age, we're going to X out two of our systemic therapies that are our go-to drugs. For instance, bexarotene or TARGRETIN, can't give it to childbearing women of childbearing age. Methotrexate, you can't give to women of childbearing age. So if it's the spouse of a person with MF who's going to be getting the systemic therapy, we have to also keep that in mind because the medicines that they take can affect the males as well, not as dramatically as women. But again, we have to have that conversation. So women of childbearing age, they're unfortunately X'd out of these two good therapies. And so we start thinking about maybe phototherapy for them if that's amenable. So that would be the first thing I would go to on a woman of childbearing age. Now, we also want to think about the side effect profile, say, of bexarotene. If patients have uncontrolled hyperlipidemia, that's going to be a problem for us, right? Because we know one of the potential adverse effects, knowingly, of bexarotene is elevations of triglycerides and sometimes even the cholesterol. So we need to screen for comorbidities and check for that. I like to tell patients about all the worst case scenario for the drugs because they will understand better if something like that's going on. So I discuss that it can change the lipids in your blood, it can change your thyroid function. So we need to know that. I also kind of keep reiterating that you're not just treating the skin, even though all the skin is involved, right? These cells have to get to the skin, so they traffic through the blood. So we do need to think about how the disease progresses, and that's one of the ways that it does. So we have to discuss all of that. That's while it's in the skin, it's not just skin. So the two choices that I have when I go to systemic therapy, I've mentioned them already. It's going to be really bexarotene or TARGRETIN, which is very targeted and very specific. And I do think that that's a good place to start if the patient's profile fits it. And so it's FDA approved for cutaneous T-cell lymphoma. So that gives the patient maybe a little bit more comfort level too, but it tells me it is specific just for that.
So, Dr. Boh, thanks. I think that one of the things that you were helping us with is really understanding some of the differentiation that you have to make with these various therapies. In looking specifically about the way in which you choose the therapies, then one of the considerations is how long do you treat these patients with that particular therapy? So can you, help us explore a little bit more about the length of therapy for these patients?
Well, it's funny you should ask me that, because we are going to present a whole session at the AAD on when do you hold and when do you fold. And that's one of the issues that we're going to cover is if they're in remission. So say they're on bexarotene, they're on TARGRETIN pills, they're doing great, they have zero disease involved, zero skin involvement, and the patient says, well, I'm clear, I want to stop. My first gut feeling is, oh, no, you don't, because it will come back. And so what I like to do is give people a long remission time before I ever consider getting off any drug. So given an example, if you have a patient who's a 2B and you put them on bexarotene and they get a beautiful response, all the tumors are gone, everything is clear, would you want to stop that? Think about this as a chronic disease. If you have a hypertensive patient and you hit a home run and you put them on the right antihypertensive, do you say, oh, your blood pressure is controlled, so let's stop it? No, we don't. I tell patients from the get-go, this is chronic. Whatever I give you, you'll be on for a while. If it doesn't work, we'll switch you right away. But if it's working, you'll stay on it. For me, it's a personal practice point that I do, but everybody's going to have a different approach. Over the years, I sometimes have done the following. Patients have been on TARGRETIN I have some patients on it 8-9 years. So if they're happy, I'm happy. But if they're doing super well, I'll sometimes go in and rebiopsy at one of the sites that we got the original diagnosis from. What you want to remember with this malignancy, it's a malignancy of the T cells that home into the skin. So they're skin homing T cells. So they have the potential, they live in the skin, and they have the potential to keep coming back. So what I sometimes will do if patients have been in remission and I'm starting to decrease their number of pills per day that they're taking, then I may do a biopsy and ask my dermatopathologist, do they have any atypical cells? If there's a residual lymphocytic infiltrate there, yes, it could be the normal T cell complement. It could be bad T cells. So I get immunophenotyping. If everything is negative, zero, there's nothing there, I will continue to try to taper off. I will tell you though, patients who've been on therapy a long time never forget how bad it was. And so oftentimes they'll stay on one TARGRETIN a day. And you're going, this probably isn't doing so well, but I don't stop it if they feel comfortable. So I really think this is a disease of chronicity, and one that I'm not very quick to taper off therapy, but sometimes we have to. So if you're going to, I start decreasing the dosage, so the number of pills. We dose it by meters, meter square, so you can feel comfortable. If they're on 6 pills, say, of TARGRETIN daily, I might go to 5. Then over a month or 2, I might go to 4. So I gradually decrease it and see where the patient falls. If nothing pops back up, then it takes a few months, but I will say we have gotten patients off, and sometimes they stay off, sometimes they go back on. So I don't push to get off therapy too soon. And I think that's the key, is going slowly to make sure that it doesn't recur. And then you can always switch them to topicals if they have a limited amount of disease. So I think we can play with our dosing a lot and just watch the patient's response and decide from there how to go.
So, Dr. Boh, you've really covered the waterfront on a lot of the aspects of treatment with TARGRETIN gel and capsules. There are a couple things that are rarely seen, but are included in the official prescribing information. And I'm wondering if you might just touch on those, because I think that's important for patients to have in their background.
Oh, sure, Michael, that's a great point. So let's start with the topicals. Okay, for topical TARGRETIN gel, like many of the retinoid gels, it can cause irritation. And part of the irritation is how it's going to work and kill off those tumor cells. So a little bit of irritation is good. So we may see what we call a retinoid dermatitis or irritant dermatitis, which is scaly, red, itchy skin, even around, but not in the area where you applied the gel. So that's one of the biggest things with the topical is irritation. And then you can get a little bit of dry skin, which can sometimes limit its use, but oftentimes we work around it with emollient. When we look at the systemic therapy, bexarotene or TARGRETIN is a retinoid. Now, retinoids are derivatives of vitamin A. We all need vitamin A, and everybody takes vitamin A, and there are multiple vitamin and extra vitamin A for whatever the reason. We want to remember that when you're on bexarotene systemically, and even be careful with the topical, that you do not take excessive amounts of vitamin A. In fact, I tell patients just get rid of vitamin A from their multivitamins and just don't take them. So vitamin A is one of the issues that we have to watch for. Of course, I mentioned about the pregnancy issues. We mentioned about the lipid dysregulation. Some of the very rare things that can happen when your lipids get dysregulated or elevated is we can see processes such as pancreatitis, which are very, very uncommon. And so we want to make sure that you communicate carefully with your physicians on that. Other things that bexarotene and the retinoids can do as a class is they can decrease your white cells, particularly some of the neutrophils, which are used to fight off infections, and it can also drop down lymphocytes, but that's how it's supposed to work. So a little bit of lymphocyte depletion is good, but we have to have a balance. So we want to watch for changes in the blood count. We want to watch for changes in liver function because high doses or doses of bexarotene can rarely cause liver damage and liver toxicity. Now, all of these are in the package insert. The reason that we check bloods on you is to pick up and watch for those potential adverse effects. Another thing that we want to watch for is we know that retinoids in general can be potentially photosensitizing. So what does that mean? So bexarotene is a retinoid, and it can, in a few individuals, cause sensitivity to sun, or you might get an exaggerated sunburn-like appearance. So you want to use caution when being outdoors, use appropriate coverage like sunscreens, sunblocks, and also sun protection gear. And all of those, though, are very uncommon, but look to your package insert so that you can get a better idea of what you should look for if one of those uncommon adverse effects should happen in your situation.
Well, Dr. Boh, I want to thank you very much for sharing your clinical experience and your outstanding patient-centered expertise. You've also really smartly pointed out the kind of the multidisciplinary approach that it takes to really manage this disease. You've brought up a need to involve oncologists, the dermatopathologist, and other caregivers along the way. And so as you're kind of being the captain for that particular patient, it is very clear that your patients have been given the very best opportunity for a clinical success. So thanks for sharing all of that.
And can I put a little plug here? I treat a lot of MF and CTCL. And I think that the regular community, private practice, or the dermatologists out there, they can do it too, but they can do it with, I like to suggest to people, because I get referred a lot by derms, I say, you can co-manage the patient with me. And so that makes it a little bit nicer because I'm at a university, but I may not be in the same city. So I like to co-manage with the referring dermatologist. If it gets to like real hairy stuff in these systemic therapies, they defer to me anyway, but I like to co-manage so that the dermatologist learns the next patient who comes in that this atypical rash may not be eczema and it may be MF, that they're thinking ahead. And so I tell my patients, you're going to stick with your regular dermatologist for all your derm needs. I can do the CTCL with your dermatologist so that they get educated and feel comfortable with it too. So they may be treating with topicals, and then they will know when it's time to go to systemic. And I'm not expecting them to do it, but they'll know, oh, come see me sooner. So that team you're referring to should be the dermato-oncologist, the general dermatologist referring, the oncologist, and your derm path. And I think that makes a nice group that the patient has on their team to take care of it. And then that patient feels more comfortable because they, in general, get freaked out when they hear the term lymphoma. And so I tell everybody, this is not the kind of lymphoma that you read about and some famous person gets it and they go on chemo, they lose their hair, and then they die. It is not that. This is one that's for almost a long-term commitment. And our derms should get comfortable with those long-term commitments. We do it in other diseases, and so we should do it in this.
Wow, that was great. Thank you both, Michael and Dr. Boh. I think we got so much more information, and I think for our patients who are watching, and we always say, you know, this is complicated, right? And it does take a village, and it's a long-term relationship that you have with your clinical team, so you can have these kinds of conversations and be able to co-manage your long-term chronic disease. And that's why we're trying to bring education about the different therapies. So patients then, when you see them, Dr. Boh, you can have that conversation. They understand the different therapies and where they are in their disease journey and what makes the most sense for them with their lifestyle, with, you know, other things that may be going on. So thank you both very much. And we're going to kind of flip the script here a little bit, and I'm going to ask Don if he would be able, you know, it's great to have therapies available for our patients, and in a rare disease, it's really amazing to have good therapeutics. But if people can't access them, or it's hard to get, or they don't know how to fill a prescription, then it doesn't help anybody if they can't get the medication. So I'd like to have you give us some insights into how do patients actually, you know, they get their prescription from their physician, Dr. Boh. What happens next? How do I get my prescription for TARGRETIN gel or capsules filled? You know, obviously it's not your regular over-the-counter kind of thing, or the thing that you go often to your CVS to get filled. So if you can share a little bit about the process and how patients can actually take advantage of TARGRETIN gel and capsules if they are prescribed. So I'm going to turn it over to you on the access piece.
Well, thanks, Susan. I'd be happy to. I'd like to start by sharing how fortunate Ortho Dermatologics is to be able to partner with the CL Foundation. Our goal is to produce and provide quality therapeutic options for providers and patients alike. After we've heard from Michael Young and Dr. Boh, I feel confident in stating that you have options with TARGRETIN. We have made available to you the gel and the caps, so you have choices depending upon what the provider may choose for you. It is critical for you to be educated on your disease and the therapeutic options that exist. Some of the providers out there may not know about TARGRETIN gel or caps, so you can ask them if they don't bring it up to you. Let me get back to access. So you can have the best product on the market, but if a provider can't get it to their patient, or if the patient simply can't afford it, it really doesn't matter. At Ortho Dermatologics, we have invested significantly to ensure that TARGRETIN can be available to the patients that may need it. In fact, let me share with you that there has been no price increase on either product for the past 9 years. We understand that quality therapeutic options are costly, and we want to do what we can to help. We have a specialty pharmacy that will help you get access to TARGRETIN, and they will help you or your physician office navigate all of the paperwork that may be associated with getting these therapies. Sendera Specialty Pharmacy will help you and your provider in very different ways. Let's talk about you first. When you receive your prescription, Sendera will reach out to you to reinforce what your healthcare provider has told you about the medication, including how to take it, the proper dosing, and what to expect if there are any side effects and how to manage them. They'll answer any questions that you may have and support you through your therapeutic journey. If you have questions about your medication or the cost of your medication, they are there to assist you. Sendero will help your provider with the paperwork that may be needed to enable you to commence TARGRETIN therapy, and they have a team of dedicated pharmacists and clinical support staff on call, willing to help you or your provider should they need it. From a coverage standpoint, Ortho Dermatologics wants to help all eligible patients that may need TARGRETIN gel or caps. If you have commercial insurance and your plan covers TARGRETIN, your copay may be zero. Of course, copays may vary depending upon the plan and state, and that is why we suggest that you and your providers go through Sendero Specialty Pharmacy, as they are best equipped to handle any issues relating to coverage. Full terms and conditions can be found at www.targretin.com. Ortho Dermatologics and Bausch Health understand that some patients may face financial obstacles that can keep them from obtaining the prescription products they need. Bausch Health is committed to improving access to medications through its patient assistance programs. These programs are listed below. Bausch Health Patient Assistance Program at 833-862-8727. Bottom line is that you, as a patient, have options. You just need to know what those options are, and we are here to help you.
Great. Thank you, Don. And I'll just remind everyone that we'll have that information on the website as well on the treatment page under bexarotene. So you don't have to remember all of that. And if you didn't write it down, it's okay. We'll have that listed on the website so you can go there for easy access and be able to navigate through. And before we just do a little quick wrap up here, I want to remind everybody that to keep watching after we're finished for some important safety information, which will outline some of those details that we spoke about. So you'll see that reeling at the end of our final comments here. So I'll just do a quick round robin. I again want to thank everybody for your time, your wisdom, your knowledge sharing, and just a quick and final thought from each of you. Don, I'm going to go with you first. Any one final thought you'd like to share with our patient audience?
I want to thank our esteemed panel on the education provided today and the CL Foundation for their continuous efforts on behalf of patients. Ortho Derm is committed to the education and reimbursement services that will help patients and their prescribers gain access to TARGRETIN gel and caps.
Thank you very much, because we need everybody to be able to get the right therapies. So that's very important. Dr. Boh, anything in final thoughts that you'd like to share with our patient?
Well, first I want to give a kudos out to the Lymphoma Foundation, because I think, and to Bausch, and I'll talk about that in a second, but the foundation makes a wonderful booklet that educates patients on the disease. And I do think that the most important part to making a successful treatment plan is education of the patient so that everybody's on board. This is a very uncommon disease. Most people have never heard of it. And so I think you really want to make sure that patients are appropriately educated. And then I want to also thank Ortho Dermatologics, because they have been very, very sensitive to the needs of all of these patients who have CTCL, and many of them are delayed in their treatment. And so the frustrations on their part, Ortho makes up for it by providing drug when patients can't get it through commercial means. And so I think that together that makes a good combination. But in closing, I want patients and providers to remember that this is, while it's a very, very uncommon disease, I think it is a bit missed, and it is increasing in its incidence. And watch for those great mimickers, because early in the disease course, you can halt progression or slow it down a lot by getting the right diagnosis. So when you see a patient with an atypical asymmetric rash, adult onset, something that doesn't fit with what you learned, or you're the patient and you're getting frustrated because your doctor's just giving you topicals and it's getting worse and you're itchy, find a person who's going to think with you and do the right thing and get your biopsies and get diagnosed, and then feel free to live your life to the best that you can.
Perfect. Well, I'll just say thanks for the plug, Dr. Boh.
Yes, it's wonderful.
Go. There's our patient's guide, so you can.
Yeah, I give it to every patient, and it has helped them so much, because they'll call my nurse and they'll say, well, look, it says on this page I'm supposed to do this if that happens. And they do. They're very informed. And when you give people the tool of knowledge, they will do far better. And that book does it for a lot of people, and it calms people's nerves, because people get nervous when you get this diagnosis initially. So it's a great asset to have.
Great. Thank you for that. And I'll also just put a little plug in for our website. If you're looking for a clinician who specializes in lymphomas, we have a list on our treatment page, our treatment centers. Look up the treatment centers. You can find it by your geography and find who's closest to you. You can also refer your local dermatologist to those experts like Dr. Boh. So you can have that combo, kind of your local derm and the specialty together. So anyway, so Michael, I'm going to let you finish us off here. Any last and final thoughts before we wrap up?
Thanks, Susan. I'll tell you what, first and foremost, this has just been an absolute masterclass on trying to understand early stage disease, as well as progression of disease, and the role of TARGRETIN in the management of that disease. And it's been my honor and pleasure to have been involved in the development of this drug, and certainly the continuing education that we're providing today. I want to thank everyone for their inputs in making this educational program on TARGRETIN possible. Our thanks to the good folks at Ortho Dermatologics. And just a note to say that the Cutaneous Lymphoma Foundation has been providing the very best information possible for over 25 years. So if any of you watching this, whether you're a patient, a caregiver, or a clinician, if you have further questions and want to support the CL Foundation, please don't hesitate to contact us at www.clfoundation.org. We greatly appreciate your engagement and your involvement.
Great. Thank you, everyone. This has been wonderful, and we look forward to more updates as time goes on. So, and again, please make sure you watch with the final safety notifications that are following this. So thanks, everyone, and have a great rest of your day. Goodbye, all.
Bye, and thank you.
Thank you.